Thank you, Dr. Nikorova, for that introduction, and thank you to the organizers for the chance to present today. In the next 15 minutes, I'm going to try to review as much as I can about really the exciting field that's emerging in the last few years of minimal residual disease in patients with solid tumors. So I think we've all know what ctDNA is, and I think this has been discussed already at length today. But just to review, ctDNA are particles of DNA circulating in patients' plasma that's derived from cancer cells. The good thing about ctDNA is the half-life is extremely short. In many studies, it's been shown to be around 30 minutes to an hour, which really allows for really kind of ultra-specific and ultra-sensitive monitoring of ctDNA in patients over time. And detecting extremely low levels of ctDNA in patients in the perioperative setting is what we refer to as testing MRD, and this stands for either molecular residual disease or minimal residual disease. This field has really moved extremely quickly. So just in the last few years, there's countless publications that are coming out, and even for folks in the field, sometimes it's hard to keep track of all of the new work that's being presented and published. Just with Signatera alone, in the last few years, you can see the body of evidence that's been generated, now including over 3,000 patients and over 10,000 time points that have been looked at in patients with solid tumors. And really, frequently we're asked, well, why did you have to develop a really new method to detect ctDNA in patients with solid tumors? Why not rely on established methods that are currently being used for complete genomic profiling? For example, identifying an EGFR mutation in patients with advanced or metastatic lung cancer. And the reason for that is levels of ctDNA in patients with early stage disease are typically 100 to 1,000 times lower than in that of patients with advanced disease. And these levels are so low that we frequently have to detect a single molecule in 1 to 2 tubes of blood and be able to do that reliably with high specificity. So the way that we achieve such high sensitivity and specificity is utilizing what's called a tumor-informed method. With Signatera, we actually start by sequencing the patient's primary or resected tumor, and this can be either from a biopsy, it can also be from a resected specimen, and we actually do whole exome sequencing. And this allows us to identify all of the somatic mutations that are present in that patient's tumor. We then select the 16 most clonal or truncal mutations, and these are mutations that occurred very early in the tumor's evolution and serve as almost ideal biomarkers of how much tumor cells that patient has. And then we design a custom assay that, once designed, can be used to monitor that patient's disease burden throughout the entire course of their treatment. Once the assay is designed, it never has to be really redesigned because, again, these clonal or truncal mutations persist in all derivative subclones of that patient's tumor. And this really opens up new possibilities in the field of oncology, namely, for the first time, being able to monitor the molecular tumor burden of patients throughout their entire treatment journey, especially in areas where on imaging there may not be tumor that's even detectable. So for example, the question can be asked, is there still cancer left in the body? And this question frequently comes up in the post-operative setting. And this question is really critical to deciding if a patient needs adjuvant therapy or can be safely observed. Also, we can ask the question, is the patient recurring? So during the surveillance setting, ctDNA MRD testing can be utilized to identify early molecular recurrence, which can precede clinical recurrence by months, if not years, and really provide a window of opportunity to try to cure these patients a second time. And then lastly, in the advanced and metastatic setting, ultrasensitive and accurate ctDNA monitoring allows us now to actively track the molecular tumor burden in a patient to really better understand if a patient's tumor is responding or not to treatment, especially in settings where imaging may be unreliable. And this data that's been generated to date has been extremely consistent. And I really like to show this slide because even though these are from 4 different studies and 4 different tumor types, these KNM plots look exactly the same. And for non-clinicians in the room, a KNM plot basically shows the percentage of patients that survive over time, or a percent of patients who have disease-free survival over time. And as you can see that in these 4 KNM plots, patients, as shown in the blue line, who become ctDNA positive after curative intent treatment have close to, if not 100% risk of recurrence with adequate follow-up in the absence of additional therapy. So if a patient becomes ctDNA positive, that patient will go on to recur in the absence of additional therapy close to 100% of the time. While patients who stay CTA negative, as shown on the green lines, these are patients who are likely cured from their surgery, and these patients tend to do extremely well. And the lead time really can vary from cancer to cancer. So how much earlier can we detect ctDNA vis-a-vis their clinical or radiological recurrence? From as short as a few months for very aggressive tumors like bladder cancer to as long as 8 to 9 months for diseases like colon cancer and breast cancer. And just diving into some more specific validation studies, so we've actually looked at CRC very closely, so colorectal cancer. And some of this original data was published in 2019 in JAMA Oncology. First author was Reinhardt. And this has now been expanded to an additional few hundred patients. And really what the question that's being asked in these validation studies is for patients with early stage 2 or 3 colorectal cancer that's been adequately treated with surgery, if we detect ctDNA in these patients after surgery or during additional follow-up, what happens to those patients with adequate follow-up? And what we can show here is that patients who are CTA positive after surgery have a hazard ratio for recurrence of 7.2. And just to kind of put that into context, what that means is that if somebody's CTA positive after surgery, they're 7.2 times more likely to recur than if they were ctDNA negative. If a patient is CTA positive after finishing adjuvant therapy, they're 17 times more likely to recur. And if they become CTA positive during the surveillance setting, they're 42 or 43 times more likely to recur. And these hazard ratios are so large that they actually dwarf every other hazard ratio that's been used to date for clinical pathological risk prognostication. For example, having a large tumor, right? So a T4 versus a T3 tumor. Or, for example, having a high-grade versus low-grade tumor. And this is so significant that when you do multivariate analysis, every known clinical pathological risk factor drops out as insignificant. And the only thing that's significant for determining somebody's risk of recurrence is a patient's post-operative ctDNA status. So just to conceptualize that in a different way, if a patient with stage 1 disease, right, is ctDNA positive after surgery, that patient will have a markedly higher risk of recurrence than a patient with stage 3 disease that had perforation, obstruction, high-grade features. But if that stage 3 patient is CTA negative, they will actually have a markedly lower risk of recurrence than that stage 1 CTA positive patient. And this effect is so strong, there's now actually discussions about thinking about revising the TNM staging criteria that are commonly used in clinical oncology to include something called TNMB, where B is going to stand for blood-based MRD status. In addition to some of this data, big prospective studies have now been started and are beginning to read out. This is one of the largest prospective randomized studies being done in Japan as part of the IDEA Circulate consortium. A similar study is opening through the NRG in the United States called NRG-008, and that's opening in the next few months. But in this study, there's a few different questions that are being asked, namely, can patients who are CTA negative be safely de-escalated from standard of care systemic therapy? So just another way to think about that is a patient who's adequately treated would typically require additional chemotherapy after surgery. Can we actually avoid that chemotherapy if that patient's CTA negative? And then similarly, the study is looking at patients who are CTA positive after surgery, asking the question, can we give these patients more chemotherapy or more treatment to maximize their chance of cure? And this study, even though it's ongoing, some of the initial data is out, and that really has shown that the Signatera assay can detect CTA in the majority of patients before surgery, the majority of patients before or at time of recurrence, and can be done in a clinically meaningful amount of time with a very low failure rate, so less than a 3% TNP rate. And some of the initial data, not surprisingly, shows that as patients have higher stage of disease clinically, right, going from stage 1 to stage 3, for example, we're seeing higher rates of MRD or CTA detection post-surgery, as you would expect since these patients have a higher risk of recurrence. There's also been studies looking at patients with so-called oligometastatic disease. So these are patients with stage 4 disease, a stage of disease we typically think is incurable, but are treated with curative intent, usually surgery to 1 or 2 spots in the liver. And in this study, the question that's frequently asked is, well, what percentage of patients are MRD positive and negative, and how do these patients do? Because clinically, this is a very difficult scenario about, to recommend adjuvant therapy or not for these patients. And as you can see in this study that's been published recently in JCO Precision Oncology, patients who are CTA negative after surgery have close to, if not 100% overall survival with now up to 5 years of follow-up. And really that suggests that even in a patient with stage 4 disease that we think may not be curable, if they are able to achieve deep MRD negativity, that patient likely is going to do very, very well, even with long-term follow-up. And also, in the field for the last few years, the question's also been floated, well, maybe what we're doing with CTA is just finding patients who are destined to recur, right? You're just finding patients pre-metastatic disease, and no matter what you do, you're not going to alter their outcomes. So that is a prognostic claim. But what about predictive, right? Can CTA also identify patients who are likely to benefit from particular therapy? And in this study done with actually Genentech called the IMvigor010 study, this study looked at patients with bladder cancer, randomized 1-to-1 between atezo and observation. The study in all comers was negative. It was a surprise. But when we looked at patients who are CTA positive post-cystectomy in the study, shown on this KNM plot at the bottom, what we're able to show in these 37% of patients, adjuvant atezolizumab markedly improved outcomes. The risk of death was reduced by over 40%, and the median overall survival was almost doubled. While in patients who are CTA negative, these patients not only did not benefit from adjuvant atezo, but there was a non-significant trend towards harm. And this was recently published in Nature. And then the last opportunity for CTA is treatment response monitoring, as we discussed. So in this study done with Merck and Princess Margaret Cancer Center, published last year in Nature Cancer, samples were collected during pembrolizumab treatment every 6 weeks and analyzed with Signatera. The striking things were that regardless of the histology that was looked at, CTA was able to be detected in patients with advanced metastatic disease 98% of the time. So if somebody has disease in their body with an ultrasensitive approach like Signatera, we will find ctDNA that can then be tracked over time. Furthermore, in patients with CTA increasing at just 6 weeks on therapy, the overall response rate was close to, if not zero. So patients who have CTA increasing on immune therapy are unlikely to benefit from that treatment, despite what, for example, you may see on imaging. And then furthermore, patients who achieve deep MRD negativity, right, so patients who cleared their ctDNA in this study had 100% overall survival with up to a few years of follow-up. And this has actually been replicated now in multiple other studies in different cancer types with different immune therapy drugs, namely that patients who are able to achieve a deep MRD negative state are the patients, the 10 to 15% of patients who are likely to have long-term benefit from immune therapy. So we really continue to advance this field by investing in prospective studies. These are 2 studies that we're sponsoring and are currently accruing patients throughout the United States. The first study is the Bespoke CRC study that's enrolling up to 1,000 patients with stage 2 and 3 CRC. That's now been expanded to also include patients with stage 1 and stage 4 disease. And here we're really looking at the clinical utility of ctDNA to drive adjuvant decisions for patients post-resection. And then the last study I'll mention is the Bespoke IO study. And this is a study that's also open at numerous centers in the United States, looking at correlating CTA dynamics to imaging in patients undergoing treatment with immune therapy. So if there's any interest in any of these sites, feel free to reach out to us after this talk. So just to conclude, really, this is a very fast-moving field. And I think sometimes it's really kind of even hard to keep track of really what's important. And I think the way we think about it is that really what's necessary is that an assay or technology to be useful in this setting has to be extremely well validated. You need thousands of patients and have to show consistent performance across numerous treatment settings and numerous histologies. Also, technologies need to be ultra-sensitive in this setting. You have to be able to detect down to molecules in a tube of blood and be able to do that reliably and reproducibility. And then lastly, you need to be able to quantitate the ctDNA. A qualitative test is not enough. Really, we have to know what the levels are and how they change over time. So with that, I really want to thank everybody for your attention And I'll pass it back to Dr. Nikolova for the next speaker's introduction.